guys today, and of course this is something I'm passionate about, and most of us are venous and lymphatic guys, and the two most common lymphatic diseases are lymphedema and lipedema, and so lymphedema and lipedema, yeah. And then so we're gonna so what is lipedema? So it's an adipose tissue disease, relatively resistant to weight loss, and is associated with high output lymphatic failure, and it's a type of loose connective tissue disease. And then lymphedema is a disruption of the lymphatic flow because of obstruction or absence of structures. And the prevalence, lipedema is estimated to affect 11% of the female population. And lymphedema is epidemic worldwide, 250 million people. It's actually much more common than we think, because as you know, one of the biggest causes are the two biggest causes that were really not fully appreciated until relatively recently are obesity and venous disease as causes of lymphatic dysfunction. So you know, this is just my favorite slide because it's got lymphatic production in there. And so here, you know, so lymphedema or lipedema, as I also sometimes say, is an increased production of lymph in the tissue, and that is filtered out. And then, you know, here is where, somewhere in this pathway is where you get lymphedema. So in the lymphatics, or in the valves, the lymphatics, etc. So lymphedema causes immobility, disability from pain, orthopedic changes, and secondary lymphedema. Lymphedema is associated also with immobility and disability, but has an increased risk of infection and cancer. This is a picture of lymphedema, and you can see the classic cuff signs. This is a fat tissue overhanging the knee, sometimes also called lobules. This is a lateral thigh lobule, upper arm lobules. These are classic presentations of lymphedema. And then this is lymphedema. Here's a you know, this foot is this right foot is more swollen. It does have a positive stemmer sign. There is actually fibrosis there. And then this is more fibrosis here. Now this is a lady with obesity and lymphedema, so lymphedema also can cause cuffs, as she has, and but yeah, so that's. So again, so these are the physical signs. Lymphedema typically has a negative stemmer sign, and lymphedema has a positive. Later stages always include fibrosis, papillomatosis, and tissue enlargement. The treatment for both is going to conservative is compression, medical grade compression. And then also a low refined carb diet. Well, I call it an anti-inflammatory, that because you use more whole foods, less processed foods, and I almost launched into my spiel, but I'm going to save that for another day. So, in addition to the conservative treatment, there is lipedema reduction surgery for and debulking for lymphedema. They're derivatives of tumescent liposuction, and they have been shown to improve pain, swelling, and decrease the need for compression. Just the end of last year, so just a couple months ago, this published. Karen Herbst and several other people helped me with this paper, and we were able to show some improvement in knee mechanics, gait, and quality of life. For these are from the lipedema reduction surgery. I'm going to go into a little more details about this paper in the next couple slides. So it was the first in the United States to look at this. So we looked at knee and gait mechanics and pre and post surgery, and then we correlated these physical outcomes and objective gait assessments with patient-reported outcomes, and these mobility improvements do correlate with future disability and life expectancy, and increased life expectancy. And then, so in these mechanical improvements were actually at least as good. So based on the literature, you up to 2 to 3 times better than a total knee replacement from what we're able to do with the reducing the lipedema tissue. So I kind of went through everybody first was prescribed the medical grade compressions, the anti-inflammatory diet. They were recommended decongestive therapy, and most participated home exercise to recommend maintain or lose weight. And so I previously had reported in phlebology on these conservative measurements, and we did see a decrease in limb circumference, a small, like a 1 to 2% decrease in limb circumference, and then a reduction in pain. But previously we did not see the improvements in mobility and knee mechanics with with the surgical that we're seeing with this surgical approach. So this is how we measure the knee mechanics. Every medical student learns how to measure knee angles and range of motion, knee flexion here. So we're, here is, this is how we determine the alignment of the knee joint. Again, so a normal knee is straight up and down hinge, and this is, this lady has about a 6-degree bend in her hinge. This is your knee flexion, and so normally you'd be able to see it all the way up to here, but just because of this tissue here from the lipedema, that you're gonna have limited knee flexion. So this is sort of before, looking more at this knee. So the average is was like 100, range from 105 to 125 before surgery, and after, it increased significantly. And so it's about a 10-degree on average improvement in knee flexion, and about a 3-degree improvement in knee alignment. And before surgery, about 20% had a normal gait, and after surgery, about 80%. This is our overall mobility. This is based on this PROMISE, which is an NIH tool, outcome tool that they developed, and it's validated for the U.S. population. And so it, before, they were significantly below average, and they improved a little over 6 points, which is highly significant improvement in overall mobility. And so dealing down into each of the little subsections of this thing is, so 16% ability to walk at a normal speed, also 16 to go up and down stairs, 27% ability to run a short distance, 12% ability to stand an hour. And so we also, 12% decrease in overall body pain. And then these are, so we looked at these quality of life measurements as well, and these SF-36, which is widely used in research. And we, and there was, on all the domains of health, from, overall physical function to, general health, pain outcomes, energy fatigue, they all improved significantly. So that's about a 12% increase in overall health, 11% decrease in 11% increase in ability to handle activities of daily living, and 13% ability to complete tasks, and a 10% increase in ability to complete by emotional pumps. We also looked at, so I pointed out those lobules, and before surgery, about 80% had lobules in their thigh, and almost a very small percent were left with lobules after the surgery, and then similar around the knee and in the arms. So I'm just gonna, this is just an overall picture of someone who's gone through several lipedema reduction surgeries. This is an example of a knee lobule here, and then post-operatively the lobule is gone. This is an arm lobule, and then post-operatively the lobule is gone. Just kind of showing the debulking of the thigh here, and how you can imagine how that would improve their knee function. This is a lady who really was a champion of the diet as well as the surgery, and that's her before and after. It could be argued because you're losing lobules, and that's one of the critical deciding points between stage 2 and stage 3 lipedema, that there is a regression in stage from the surgery, and so that's helpful. Well, thank you very much. I want to say a few other things. So lipedema was described by vascular medicine doctors up at Mayo Clinic, and it is this is our space, and I feel like as fellow venous and lymphatic guys, we need to take care of these patients, including, I think, more of us need to be doing surgery to reduce lipedema. So, in addition, but I think it's absolutely critical that we also manage them effectively, comprehensively, because it is, and we're really the only people that can manage them comprehensively. Yeah.
So you're talking about managing them comprehensively. What do you do in your office with these patients before you do the debulking kind of surgeries? I mean, I can think of a million and one things, because this is kind of like what I love to think about. I'm a little geeky on that. But what do you do? Because I just am interested in what you would tell your consult that comes in with us, beyond the fact that I've just given them a diagnosis and they love it when you give them a diagnosis and you point them to the websites, and they're just like, oh my gosh, someone named it. And I don't really care about the name. I care about, okay, now what? So I want to know what your now what is pre-surgery?
So I'm very, I go into and explain with every patient why it's so important for compression, because how it improves lymphatic flow and how that lymphatic impairment leads to fat accumulation. Any limb that has lymphatic impairment is going to accumulate fat in it over time. So that and that's you. And I think we all have to. You have to almost really educate / sell them on that, because it's a big commitment to wear compression every day. And then I go through the diet, and some who have a second, like if they're significant secondary obesity, we'll talk about weight management things, and sometimes I'll refer off for weight management. And everybody, before I do surgery, they have a period of conservative therapy, and that's different than the way, like a plastic surgeon will manage this, who someone should up. They're not as devoted to the comprehensive, because this is not, even though, yes, I'm very proud of this paper, and yes, it does show significant benefit, but this is not, surgery is not a cure for this. This is a lifelong disease. This is a disease that this patient, and I feel like even for them to look at it as just a surgical disease, is wrong, because they can, if they do not adhere to the diet, if they do not adhere to the compression, if they do not make those lifestyle changes, they will, they could get reaccumulation, they could, progression. You can't treat this as just a surgical thing. Yes.
To go on with Tom's point, the conservative measure part that we do from the lymphatic physical therapist standpoint, I feel like they do a much better job than I can in my visit in terms of giving those tools, be it the diet, exercise, all that. And if any of the surgical options, come on the horizon for these folks, you're gonna have to have some documentation of that. And for those folks that went down the pathway, for surgical treatment, and we've co-managed you folks too, Tom, and I appreciate that. They need to have that artillery to work with their insurance, that they've done this, that they, at least 2-3 months of PT, that, weight loss regimen as appropriate, but there's a lot of strength to be able to give something to a patient that they can hang their hat on a diagnosis, because if we aren't recognizing this, they're going to TikTok and find it. There was one patient showed up, and she's like, "Oh, this is great, doc, but this is exactly what I found on TikTok." Oh, okay, we should be the one. I don't encourage going on TikTok, but I think that's helping these folks out and doing education is huge.
Can I chime in on that? A couple of years ago, we started the Lymphcast podcast, which has been a very, very successful resource for people in the lipedema and lymphedema space. And these are